So the topic, as we are all aware, is like impaired cognition, hypertension, poor growth, and right-sided heart failure. So, this is a recommendation which talks about the various stages of childhood and adolescence, what is the normal physiology. Then we have neurological conditions like epilepsy, then we have neuromuscular disorders, posterior facial malformations. We tend to see insomnia and various forms of sleep-related breathing disorders and apneas. Then we have genetic syndromes. It's brief, economical, less burden on patient, but there is an issue of recall bias and reliability. The question is because we're applying them one time when they're at our clinics. The sleep logs and diaries, they have a day-to-day variability documented at various settings. There is less bias, burden on patient is there because patient has to note it down every day. Then we have actigraphy. The purpose.
Good evening, everyone. Today I'm going to present two cases from our study to understand the sleep's role in epilepsy and cognition. Epilepsy is one of the most prevalent. Appears to be active and during sleep, clears the brain waves and reduces the seizure risk. Hence, we thought of doing our study to Master H, 13-year-old male child, who's a known case of primary generalized epilepsy, was on valproate at 30 mg per kg per day, and the child remained seizure-free for more than 1 year. After enrolling in the study, we went ahead with the sleep evaluation questionnaire. In this, the child had history of impaired social performance, behavioral problems in the form of irritability, had snoring while sleeping, had excessive movement of the limbs during sleep, and the child also used to complain of leg pain, which of self-limited epilepsy with centrotemporal spikes, was on levetiracetam and clobazam, and the child remained seizure-free for 18 months. On sleep evaluation questionnaire, the child was found to have lack of attention, behavioral problems in the form of hyperactivity. The child used to sleep off later than the conventional bedtime, and the child used to move her legs during sleep. We went ahead with sleep log. Sleep log was filled for 1 week prior to the polysomnography, and in this, the child used to sleep sleep after 12 a.m. in the night, and the child in the weekdays, the child used to get up at 6 a.m. as she had
diagnosis of nocturnal paroxysmal events to differentiate whether it's a true epileptic event or a parasomnia event, because the treatment are diametrically opposite. So early recognition of parasomnia mimics is warranted for targeted therapy, and epilepsy is a state of cortical hyperexcitability and hypersynchrony, whereas parasomnia is a state of dissociation and arousal regulation failure. So always it's essential to evaluate for neurobehavioral comorbidities associated with sleep disorders, and the minimum level of ferritin to maintain in the sleep-related movement disorder is 50 microgram per liter. Thank you for this wonderful opportunity. Thank you.
Right off the bat, you don't see that in a sort of a banal non-epileptic, non-REM parasomnia. So I think that sort of is a giveaway. But I think the video was really very helpful for that. And so that's kind of all I had to say. It was really a very nice session and excellent presentations by all of you. Thank you.